started. My name is Eric Huck. I'm the co-founder of PA Lyme. I'm also a regional leader of the Harrisburg region. I wanted to open with some state news, federal news, and some other news as it relates to Lyme. I mean, Happy New Year to everyone. At the date of this recording, it is Tuesday, January 19th. This is our first virtual Lyme impact session of the year. So Happy New Year to everybody and welcome. From a state legislation news point of view, there's a whole lot going on. Last year, there was a lot of fits and starts for some Senate bills and Lyme legislation. It never coalesced, and we ended up really not doing anything, and the state ended up not doing anything. A lot of that was largely driven by, COVID and what was going on. But here in the state, Senator Michelle Brooks has launched a process to introduce 4 Lyme bills in the PA Senate. She's done this by sending out co-sponsorship memos to all the senators. So these include a Senate Bill 100, which is our old original Senate bill, which in the House was House Bill 629. If you recall, House Bill 629 had a lot of traction last year when it went into the Senate Banking and Insurance Committee, and that's where it kind of really languished. I will say that there is a new Senate Banking and Insurance chairperson, John DeSanto. So Senate Bill 100, which allows for insurance reimbursement and doctor protection, we're hopeful that that gets a new audience. Another PA Lyme bill that was put out was a mandatory Lyme education bill for medical professionals. This is something that really was inspired by Representative Rosemary Brown last year, and it looks like that might get a viewing. In addition, a school education bill for students that would look at tick awareness, prevention, proper tick removal procedures. This would be a bill that really is directed to the educational facilities as it relates to grade school children. In addition to that, a bill focused on improving testing, something that would ensure insurance coverage for a broader range of tests. If you are like many of us that have chronic Lyme and you've done blood work and testing with some other labs, you might have had your insurance coverage denied for that. Some of the blood labs, IGeneX, MDL's out there, Galaxy, there's a whole host of them. So this is a bill that would really broaden the scope of ensuring insurance coverage for a broader range of tests. In addition to all that, in the House of Representatives, Kathy Rapp is also launching a Lyme bill that would really be something that is a little different than the other 4 and is one that we have some encouragement about that really is around CME testing. So with that, on the federal front, I think most of you that are familiar with Lyme and what's going on within the different legislators, there's a tick-borne disease working group. It was established by Congress in 2016 with the 21st Century Cures Act. It is a committee that directs their findings to the Secretary of Health and Human Services. They give recommendations and give suggestions for federal response to tick-borne disease prevention, treatment, research, and it looks at the gaps that are in the federal system as it relates to tick-borne diseases. I'm really very pleased to say that Julia Wagner was nominated to a subcommittee of the tick-borne disease working group. She's been nominated. We have not heard. We are pleased and hopeful to have her on one of the subcommittees and the committee with her as a co-founder of PA Lyme and starting Lyme Action PA. She really would represent our interests very, very well. I want to end before I turn this over to Dr. Bransfield. I want to end on the RICO lawsuit. You may be aware of this, and if you're not aware of it, it keeps getting better. There's a lawsuit that was filed in Texas, Torrey et al. Versus the Infectious Diseases Society of America et al. It was a lawsuit filed in 2017 on behalf of Lyme disease patients who say they've been denied care and harmed by the existing insurance and medical protocols. Earlier in 2020, the judge upheld conspiracy claims under the RICO statutes. That is the Racketeer Influence and Corrupt Organizations Act. RICO, if you're familiar with that terminology, that is a section of the law that really brought down the mafia in New York City. And so the judge upheld the RICO claim. He refused to dismiss the claims against the doctor defendants and the IDSA. He said there's jurisdiction that those defendants are grouped under this type of a conspiracy claim. So in November of 2020, just recently, all 8 insurance companies have settled. Very, very interesting. All of the insurance companies have settled. They do not want to go to trial. And the plaintiffs are going to move forward with a lawsuit against the 6 physicians and the IDSA, and the trial is slated to be September of 2021. Pretty exciting stuff. A lot of us in the Lyme community have been saying, when is somebody going to sue somebody? When are we going to get some human rights? When are we going to get some civil rights to be able to prove that our rights have been denied and we've been jeopardized care by the cabal of those entities that have conspired, using the words of this lawsuit, to put a system in place that works against us. So if you've got a child or a family member of yourself with chronic Lyme, this is something that you should be pretty passionate about. With that, I want to shift gears, and I do want to turn this over really to Dr. Bransfield, and I'd like to give a proper introduction of Robert Bransfield. He's a graduate of Rutgers College and George Washington University School of Medicine. He completed a psychiatric residency training at the Shepherd and Enoch Pratt Hospital. He is a distinguished life fellow of the American Psychiatric Association. In addition to that, he's a clinical associate professor of psychiatry at Rutgers, the Robert Wood Johnson Medical School. He has authored a lot of publications, peer review articles, literature, medical books, and other journals. In addition to that, as if that's not enough, he's a past president of ILADS, the International Lyme and Associated Diseases, as well as the New Jersey Psychiatric Association. He has a lot of distinguishing credits to his benefit. Very accomplished career, as you can tell. If you follow him on Facebook, please look him up, Robert Bransfield and COVID-19. He's probably, at least in my estimation, one of the leading authorities in the United States on neuropsychiatric Lyme and its implication with tick-borne diseases. So, Dr. Bransfield, we're very, very pleased to have you today. With that, allow me to turn it over to you. And if you want to jump right into it, please do.
Hey, just one thing before Dr. Bransfield starts. We were able to go live on Facebook, so we are now on Facebook Live.
Very good.
Okay, good. And thanks for inviting me. And I'll turn on my slides here. Let me see. There we go. Okay. All right. So this is a program we were going to do a few months ago, but and basically I want to do an overview and talk about the neuropsychiatric symptoms that we see with Lyme disease and try to explain it and go into a little bit of detail about it. Okay. Now, what I want to do is look at the connection between tick-borne disease and mental illness, and then discuss the symptoms. How can that lead to symptoms? How can we address these symptoms? And then I want to touch on a number of different areas, such as the recent IDSA guidelines and their relevance with psychiatric symptoms, and Lyme and COVID-19, which that keeps coming up as a timely issue. And then I'll discuss some recent articles and videos and overview that. And the links to those recent things I'll put on, maybe we can put on that YouTube or the link at the bottom when you have the video posted. Okay, so just looking at an overview, you get an infection, and then it's not so much what the infection does, but how that affects the immune system. And the action of the immune system is often what causes many of the symptoms we experience. So think of it like friendly fire in a war zone. Some of the symptoms are directly caused by the effects of the pathogens or the tick, but some are caused by the immune system reacting to that infection. So it often leads to a rather complicated picture. Now, think of an example of a fox hunt. If I were to wander through the woods looking for foxes, I probably wouldn't be very successful. But when you have people, horses, and dogs, which are 3 different species, it has a much more magnified effect than any one species alone. Now think of that with tick-borne infections, and we can think of the term complex interactive infections. When you have multiple infections, it's not just an additive effect, it's an interactive effect. So a lot of times these infections, and the infections that give the greater difficulties aren't just Lyme, but they're a combination of Lyme and other pathogens. And it's also, not only is it the pathogens, but then different people have a different genetic susceptibility or different susceptibility. Then you get that infection, and then you get disease progression that evolves over time. And we see the early symptoms, later symptoms, and each person has a unique presentation. So this is in medical school, we call this a St. Sebastian diagram with arrows all over the place. But if you take a minute, it really makes sense. So you get the infection, and infection alone doesn't mean illness. But if there's something pathological where it's harmful. So look at that to the left there, and then that provokes the immune system. There's an interaction there. The immune system then causes symptoms, but the pathogen also causes symptoms, and that causes disease progression. And a person then is stressed by those symptoms. That chronic stress can make the person more immunocompromised rather than immunocompetent. And then that contributes to the progression of the infection and the disease process. And not being aware and mismanaging it can further add to that. So that's often the vicious cycle of pathology that we see with people when they get entrapped by this disease. Now, one key thing is that your body heals, your immune system is activated when you sleep. And a very high percent of patients with Lyme disease have non-restorative sleep. And that contributes to that vicious cycle of disease progression. And non-restorative sleep is associated with fatigue, cognitive impairments, emotional impairments, greater sensitivity to pain, endocrine dysfunction. But the big thing is immune dysfunction. So when you're not sleeping well, your immune system isn't acting as well, and you're not healing, you're not recovering. So sleep is critical with that vicious cycle, and that's a key thing often in considering treatment. Many people with Lyme describe themselves as feeling wired and tired, that they're wired and they can't sleep, but they're tired, they're fatigued. So as time progresses, an early infection can be the bullseye rash or mild cognitive problems, mild emotional problems, some what we call vegetative symptoms with sleep, decreased libido, appetite being off. And then as time goes on, we see these symptoms increase, and then we see the more severe symptoms. Usually myself as a psychiatrist, I see people after they've been infected for years, because that's usually when you see more of the psychiatric symptoms. You see the milder cognitive symptoms first, and the more severe psychiatric symptoms usually after a period of years, where someone missed the diagnosis or inadequately treated at an earlier stage of opportunity, when much of this could have been prevented by earlier recognition, earlier treatment. Now this shows a before and after picture. So this is a SPECT scan, and SPECT is a type of imaging that we can do where we can take a picture of brain activity, and the darker it is, the less activity that's there. Now this is a person who was very high functioning, a high functioning professional, and then they had a number of months of ceftriaxone treatment. And after treatment, then they became higher functioning again. And you can see how the brain lights up better after treatment. So it's a before and after picture. That's one way of visualizing. So when I first was in medical school, we couldn't visualize the brain like this. Now we can. And it really helps us to understand these things that previously we referred to the brain as a dark box that was very hard to comprehend. Another way we can visualize things sometimes is with MRIs, and that shows lesions. And a lot of times we see what we call white matter hyperintensities. And you think of the brain, the outer part is gray matter, and that's more memory content. Whereas white matter is more the connections. And a lot of the problems with Lyme are more white matter problems. So there's trouble with slow processing, trouble recalling, and here we see impairments in white matter that go with that finding. Now, you only see these findings usually in about 20% of Lyme patients on an MRI, but you know, they're more subtle, that not everything can be measured with these brain imaging tests. So this is a recent chapter in a book that just came out a month ago that we worked on. It's really out of a group that I collaborated with in Europe. And in here we looked at PET, which is another way, different than SPECT, another way of showing brain activity. And what it shows is that when we have infections, including Lyme disease, that you can see inflammation within the brain. Now, inflammation is a big part of the symptoms that are associated with Lyme disease. And the inflammatory cells in the brain are what we call glia or microglia. So we can see activation of these immune cells associated with these infections, and that helps explain the physiology of how you get this infection, and then that leads to mental symptoms. So it all makes perfect sense that you can connect the dots and explain things. Now, this is a cartoon that actually 25 years ago we did this, but it describes what happens to the average Lyme patient 25 years ago, but I think it still happens today. Now, that fellow in a wheelchair looks a little bit like Alfred Hitchcock with the movie The Birds, if anybody ever saw that, and he's dealing with the birds here. So he's saying he's late, someone made a loud noise, honked their horn, he lost his temper and then forgot where he was and got lost, and he's in a wheelchair and he has some spirochetes dripping off of him. So that's a puzzling diagnosis to make. So we have a seagull in the ivory tower that says only double-blind research is valid, so we don't know what's going on. And a doctor, there's a doctor there on big bucks insurance. You know, what Dr. Quack says, the blood test is negative, you don't have Lyme disease. And then the insurance doctor says, that's a brilliant diagnosis, Dr. Quack. We'll keep you on our referral list. And then the patient's frustrated and things go on. So that was 25 years ago. And I would have hoped things would be different now. So Lyme sufferers are sometimes victimized in three ways. Once by the disease itself, then by doctors who may not understand. Often a patient doesn't understand himself, what's happening to me. Then their family doesn't understand, doctors don't understand, and loved ones don't understand, and then they walk away. So it's very traumatic to people. Now, one article I did recently was looking at what's psychosomatic or somatopsychic. And a lot of times people are told, well, it's all in your head. And as I showed with the brain imaging, some of that is in your head, but it's not like you're imagining it. It's not real. It's not really psychosomatic. And there's a lot of different words that people are thrown around: somatic symptom disorder, medically unexplained symptoms, conversion disorder. And I analyzed each one of those phrases and analyzed it in this article and looked at whether it was valid or not. And a lot of these things aren't really like it's in your head and then it goes to your body. It's more, it's in your body, and then you may have a physical reaction causing emotional or cognitive symptoms. So it's more somatopsychic than psychosomatic. Although there are some somatopsychic symptoms that people sometimes get, but then there's also what we think of as systemic illness, multi-system illness that affects multiple parts of the body, including the brain and the body. So it's an effort to sort that out. So this is a diagram showing that you can have multi-system illness that causes both psychiatric and general medical problems. And it's if you have physical conditions, you have a psychiatric impact from that. But if you have things affecting the brain, that can also affect the body. And some things, there's just an unknown element to it. And when something's so complicated, there's often a lot of medical uncertainty. So we look at that and try to tease that out, and the devil's in the detail about trying to understand how these things interact with each other. So what happens is Lyme is somewhat like a shotgun injury, where if you have 100 people who are hit by a shotgun, there's a lot of similarities, but each person's a little bit different. So some people get Lyme and have no effect but we see that with COVID. We see that with meningitis. We see that with many infections. And then other people have a broad spectrum of multi-system symptoms. And then often we get the early symptoms like I was talking about, and then the neuropsychiatric are usually later to appear. And although there's some general presentations, and some people, it's latent for a while, then they have a car accident, they have surgery, they have some trauma in their life, and then boom, it seems to reactivate a latent case of Lyme disease, occasionally childbirth. So it may sit there for a while, just like what we see with someone who gets chicken pox, and then years later they get shingles. It activates something that was previously latent and not there. So there's many faces. It can present in many different ways, and it can be variable in people going from one pattern of symptom to another over time. They can have good days, bad days, and there's a pattern that can be hard to explain sometimes. We can see congenital problems, and there's about 60 articles now of congenital Lyme disease. So that's something to be attentive to when someone is pregnant and there's active Lyme, that treatment is a consideration. And you can see developmental problems. There's autism, and I've done a few articles related to this, or autism spectrum. And when we look at that and analyze it, some of these infections are not just Lyme, but we could think of Babesia, Bartonella, Ehrlichia, other types of Borrelia. Lyme is what we call a spirochete, and one of those spirochetes are Borrelia, but there's other Borrelia besides Lyme. And then there's Ehrlichia, and then often we see an activation of these viruses that are opportunistic: chlamydia, mycoplasma, Mycoplasma fermentans. So, and then there's the immune reaction to that. So it's a very complicated formula. So it's like a symphony of pathology. And think of when you get a tick bite, you don't just get a tick bite. You know, the tick is drawn blood from from whatever wild animal was in the forest. It could be mice, rats, skunks, possum, deer, who knows what. And when they draw that, then that gets injected in you. So you never know what you get a transfusion from wherever that tick has been. They live in filth. So this is an article that I did, and this is basically the main thing I'll be talking about tonight, is looking at what are the pattern of symptoms that we see in your average patient with Lyme disease. And I've treated many Lyme patients, thousands of Lyme patients over a period of decades. And I've seen certain patterns that are quite predictable. And that's how you make a diagnosis in medicine. It's pattern recognition. And you know that pattern can be variable. But what I took 100 patients that no one could argue, is this really Lyme disease? So they were well-validated patients who had met the CDC criteria of Lyme disease. And then I analyzed those patients and said, what are the symptoms these patients have? And then I figured out some diagnostic symptoms based on that. So these are, this is something you can look up and say, how much do I relate to this? So when you do a study, you do a control group. And I did 4 control groups. A lot of studies only have 1 control group or none, but I did 4. So the control groups were, first of all, the 100 patients before infection. How were they before versus after? What symptoms did they have before versus after? Then I did my survey, and the survey was 280 some questions looking at different symptoms. I did that survey on healthy medical students and who do not have Lyme disease. Then I did the study on people that had chronic illnesses other than Lyme disease. And then I used what was called the National Comorbidity Study. And what that was is people went around and took a survey to find out what's the prevalence of different psychiatric illnesses in the general population. And I used that as a reference point for my baseline of these patients before they became ill, to see if my baseline was valid. So in looking at that, the average patient who had Lyme was really very healthy before they became infected. And they had an average of 4.6 clinical findings before Lyme and 82 clinical symptoms after Lyme. The average medical student had 4 symptoms, so very similar baseline. Whereas people with other chronic illnesses, an average of about 22 symptoms. So other illnesses had some symptoms, not as many as what we saw with Lyme. And then I used what was called the National Comorbidity Study. And here's how that works. That was that survey I spoke about. So we could argue, well, was my data accurate? So when I looked at my patients and I said, were you depressed before Lyme disease? 9% said yes, whereas the National Comorbidity Study said 8.2%, very close. How many of you were bipolar before Lyme? 3%, they said 2.6%. Panic attacks, I had 2%, they had 2.7%. So you could say social anxiety disorder, I found 7%, they found 6.8%. Generalized anxiety, 3%. So you could see that it was very accurate that my numbers pre-infection correlated with the findings of psychiatric illness in a general population. So let's look at these symptoms and let's break it down, because there's so many symptoms, it gets very confusing. So you could start with looking at the cognitive symptoms, such as attention span. Now, attention deficit disorder is maybe about 10% in the general population. Now, this is a lot of numbers, so I don't want to make it too complicated here, but you're really looking at the third column. So basically, when I look at each of these symptoms, your average Lyme patient who I see, and I recognize that this is the Lyme patient that would be sent to a psychiatrist. So those are probably Lyme patients that have more of the psychiatric symptoms. So it may not be representative of every single Lyme patient. The average patient in the general population, the average person has 7% incidence of attention deficit disorder, and that goes with a lot of studies that we see. Whereas after infection, 84% have attention span problems. So we have a lot of attention span problems, and then we can break it down easily: distractibility, trouble prioritizing attention, sensitivity to sound, sensitivity to light, sensitivity to touch, sensitivity to smell. And what's different, it's not exactly like what we see with attention deficit disorder patients. A lot of Lyme patients get what's called sensory overload, where it's just too much. They can't filter out stimulation. It's overwhelming. And that's different than ADD, where there's distractibility. But that I don't have numbers on. Some of these things I have data, and some of the symptoms that I thought about later, I didn't have all the data. Then we often see memory problems. So the point I'm making here is that you have all these symptoms. And now at the very end, I'm going to talk about a movie called The Monster Inside Me. And I watched that movie last night, and I'll talk more about it. But that kind of reviews what it's like to go through this. And it's a very, very interesting movie, and that shows it. So this is more what supports it and validates all this. So there's memory problems, working memory. You walk in the next room and you forget what you went in the next room to get. 78% of patients have that. Short-term memory problems. A lesser amount with long-term memory problems, and that was like 35%. Again, look mostly at the third column. The second and fourth column really look at statistical validity. So that has to do when you're nitpicking about how valid these numbers are. But it's basically, it shows these numbers are valid. And then word finding problems, trouble recalling names, getting lost in familiar places, trouble remembering faces, motor memory. You have to think out, like, how do I tie my shoes? I have to micromanage that. I have to think about that. I can't just do it. And then you often see some dyslexia type problems. And that's what we think of as processing impairments. Trouble with fluency of speech, trouble with reading comprehension, spelling errors, word substitution errors, coming out, retrieving the wrong word, and impaired handwriting, letter reversals, trouble with fluency of speech. A lot of times it's a little bit like a Peanuts cartoon, where when the adults are talking, it's wah, 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 wah. So it's like you're hearing the words, but you're not processing it. Now, this is what goes with that slide I showed with brain imaging, where I was talking about white matter problems. And that has to do with processing. It's like a slow computer. The old computers where you would go on the internet and it would take a minute to download. So when you process information coming in, it takes a while, and then it takes a while for you to process what you want to say. So there's that delay. So it's hard and very frustrating for many people with Lyme disease to keep with the pace of people around them that are operating more quickly. Left-right confusion. So there's this breakdown of all these processing impairments. Then another part of cognitive abilities, and we're still looking about thought, and this is the outer part of the brain, cognition, thinking. We have attention span, we have memory, we have processing, but executive functioning is your higher power, and that's the ability to create and sustain goal-directed behavior, okay? So there's different parts of that. For instance, brain fog. If you don't know what brain fog is, anybody with Lyme, I don't know that I have to explain it, but if you don't know what it is, take 100 milligrams of Benadryl in the morning and go about your day, and then you know what brain fog is. Trouble concentrating, trouble prioritizing, trouble multitasking, apathy where it's hard to take initiative, obsessive thoughts, intrusive thoughts, time management problems. A lot of Lyme patients, time escapes them. They have great difficulty with time management. And then imagery, and this is something that I've done in articles about, but it's hard for people to understand this, and people are often reluctant to talk about this, that images like this can come into a person's head from nowhere. So it's like, where did that come from? And it's, so we can see nightmares, which are intrusive images or intrusive thoughts or intrusive dreams at night, or daymares. And they can be aggressive, horrific, or there can be musical hallucinations where you hear music and it's not like a schizophrenic hallucination. And it's not an earworm. It's like, it sounds like there's a radio in the next room and you can't pick the station. And, or in images that come, be they aggressive, sexual, otherwise. So this is a description from a patient, and they describe this. And I think it was rather accurate, and I've had many people describe it in a somewhat similar way. Frightening, stabbing, horrific images. So it's almost like me flipping channels and going to one of these horror movies and flipping from one station to the next. Death, dying, pain, and suffering. Often gory and unreal, if in a horror story. Faces with blood or exaggerated awful expressions. Visions of stabbing or killing, often of those close to you or familiar. Episodic and not continuous. Worst possible situation, helpless stumped bodies. These images don't seem to necessarily be associated with a particular occasion, place, or time, but come and invade the privacy of my mind. So that's hard. And when someone has this, they're often reluctant to talk about it because it's, what's wrong with me that I have this coming in my head? Where's this coming from? And we think of this as related to inflammatory reactions in the temporal lobe. You can see this. It's a lot like post-traumatic stress disorder, and because that has intrusive symptoms as well. So now we go on to other groups of symptoms like emotional symptoms, low frustration tolerance, 80%, sudden mood swings. Anhedonia is the blunted pleasure of life. So you can go through life, but it's hard to feel the joy of life when you're doing something. Crying spells, being hypervigilant, being more hyper-aroused than you need to be. Paranoia, depersonalization. Depersonalization is a hard thing to explain. That was 64%. It's almost like Scrooge in A Christmas Carol, where you're there, but you're not there. And the opposite of that is presence. I think of command presence, or when with a military general or stage presence, you feel like a ghost. There's a detachment that a person feels, and it can be very disconcerting and difficult to feel. Or derealization, where things around you aren't real, or dissociative episodes where you're in an altered state doing things that you're not in control of. And then different behavioral symptoms. Number one on the list was poor job or school performance. One person that worked in one of these big funds in New York got Lyme disease, and their judgment was a little bit off, and they lost a couple $2 billion. And when you're in a job that requires high performance, a little bit of cognitive decline can have a big impairment. Decreased social functioning, a tendency to be more easily startled, explosive anger, marital problems. I see a lot of divorce, a lot of marital discord, a lot of family conflict, being more accident prone, being suicidal, substance abuse, legal problems, occasionally, assaults, and to a lesser degree. Now let's talk about suicide for a minute. That's one of the things that we see. And I did a study on suicide and found that I estimate there's about 1,200 Lyme-related suicides a year. That's the leading cause of death related to Lyme disease. Now, part of that is the way the brain is affected biochemically pushes someone towards suicide. But there's also the stress of dealing with all these symptoms and people not understanding it. So there's two parts. There's that biological part, and there's that social part. And if we could understand it, address it better, I think we could reduce a lot of these suicides. And this is something that doesn't happen a week after you get a tick bite. This is something that occurs over time. And when we get on top of these illnesses and turn it around, we could save a lot of lives. Violence. Now, most patients not violent, but when Lyme affects so many people, and the latest statistic that came out with the CDC used to say, well, It maybe is like 30,000 people a year. And then they revised and say, well, I guess we were wrong because we looked at insurance statistics and it's more like 300,000. Now they looked at it again, it was 476,000, and even that's an underestimate. And Michael Cook just did a study where he looked at dogs compared to people and did a different way of calculating. He came up with 473 cases per year in the United States of Lyme disease by a totally different method. So he came up with the same numbers almost the CDC came up with. So violence, and it's rather a unique pattern of violence that we see with this, and particularly with children where they don't have the maturity and the reference point. So I did a study on violence, just like I did one on suicide. And think of three basic kinds of violence. One is impulse control, and that's the most common violence. That's particularly what we see in hospitals, like a Saturday night special at 2 o'clock in the emergency room where someone loses control. And sometimes that can be provoked by the intrusive symptoms I was talking about, or the sensory overload or frustration. But we can also see psychotic violence, or sometimes predatory violence. Predatory violence is particularly problematic, and that's when I was talking about some of the mental symptoms, one thing can be how it can affect personality. Now, when it affects the temporal lobe, certain parts of it, what we call the amygdala, that's an emotional center. When it damages that area, and there are a number of infections that can do that, not just Lyme, particularly see it with herpes too, that can cause a lack of empathy. And that can go with predatory violence, which is in many ways the most dangerous violence. And that's what you might see with serial killers, for example. And that's a less common thing, although I've seen all three forms of violence emerge in someone who, from these infections, who did not have this before they had it. Now, invariably, when you see that, it's not just Lyme. It may be Lyme, Babesia, Bartonella. It's often a combination. It's a complex interactive infection, like I was talking about before. So we can see, even though the average person doesn't get this, but a lot of people just get kind of some impulsivity, low frustration tolerance. You see that quite often. The more extreme forms are a much lesser number, but since this affects so many people, even if a very, very small percent of the population get this, it's very, very significant. And we can not only prevent suicide, but we could prevent some senseless violence and save lives. Other psychiatric syndromes that we can see, for instance, depression or obsessive compulsive disorder. So depression, 79%. If you recall, when I compared that with a comorbidity study, 9% before, but a lot more than that after Lyme. Generalized anxiety disorder, panic attacks. Now, when you see panic with Lyme disease, it's different than other kinds of panic attacks. Most panic attacks are only a few minutes, but they may feel like an eternity. With Lyme disease, you can have panic attacks that can last, some people call it rolling panic attacks. They can last more than a half hour. They can last an extended period of time. Whenever I've seen long duration panic attacks, it has always been a result of Lyme disease. A lot of social anxiety where you feel like other people are scrutinizing you. It's your own self-scrutiny that you're projecting on other people. And this was someone who didn't have social anxiety before. Or obsessive compulsive disorder, post-traumatic stress, or bipolar illness. Bipolar we particularly see when someone's infected very young, not so much when someone's infected at a later age. And then fatigue and sleep problems. And those two things go hand in hand. Fatigue is a number one symptom. That's the number one symptom that people complain about in studies, and fatigue is lack of energy unrestored by rest. So it's not just sleepiness, but your battery power is low. One of my patients said to me, well, I got up today and I knew I had to wash the dishes and I needed a shower, but I knew I could only do one of those two things. And once I had to pick which one I would do, And once I did that, I knew I was done for the day. That's big time fatigue, where you don't have much energy. And it's a lot of people compare fatigue to exhaustion, where, well, I ran a marathon and I feel exhausted, or I studied for 12 hours and I feel mentally exhausted. But that's where you did something to show for it. Fatigue, you could sleep for 14 hours and you feel exhausted as if you ran the marathon when you did not. And fatigue strongly correlates with non-restorative sleep. You're not recharging your batteries when you're sleeping properly. And we can see abnormal patterns on sleep studies. So a lot of times there can be excessive drowsiness during the day, trouble falling asleep, waking up in the middle of the night, early morning awakening, and erratic circadian rhythm. A lot of Lyme patients stay up late and get up late. And what often happens is, because of the sensory overload, the sound sensitivity that a lot of people have, they often hide from people, and then they're at peace at night because they can hear themselves think, and that's the best part of the day, and then they get this shift. We also see narcolepsy and sometimes cataplexy, sleep apnea. Those are more extreme, but the narcolepsy can be an autoimmune pattern that's seen with some patients. We can see eating disorders. The eating disorder might be early weight loss and later weight gain, and loss of appetite, then carbohydrate craving, excessive weight gain later in the disease, sexual problems, decreased libido, sometimes hypersexuality, but more commonly decreased, and then temperature control problems. This is where it affects the brain stem. So a lot of the cognitive things are where it affects the outer part of the brain, what we call the cortex. The emotional is where it affects the middle part of the brain, the limbic system, and temperature control, heat tolerance. These are things that affect what's the brain stem: eating, sexual functioning. Headaches, we see a lot of different headaches, different kinds of headaches. It's a symphony of headaches. We can see pressure sensation inside the head. We can see headaches come from the neck that radiate up into the scalp. We have TMJ headaches, bitemporal headaches, which the master muscles in the temple, sinus headaches, migraine headaches, cluster headaches, a ice pick, thunderclap, like you're jabbed by an ice pick. You can also see headaches that are provoked by sexual activity. My dog is here trying to jump on my lap, so he may come in the screen, but I'm not sure the screen is showing right now. And then now there's the part of the brain that we call the cranial nerves. There's 12 cranial nerves. And the part that people recognize the most, and was recognized in early description of Lyme disease, is Bell's palsy. But it also affects a lot of eye problems. So there's a long list of eye problems. I'm not going to go into them all. And this is the Bell's palsy with the 7th cranial nerve. And a lot of these problems are with the 8th cranial nerve, which is hearing. So that can be associated with dizziness, motion sickness, vertigo, Tolios phenomena, which is loud noises make you dizzy and nauseous, and or a feeling that you're on a boat and that you're rocking on the boat, and that you can't get off the boat. But it affects other problems, choking, and I'm not going to go, but this is how we do the assessment. And then seizures, partial seizures, I see mostly. I don't see as many as I used to because people are getting diagnosed earlier than they used to be, so I don't see as many as I used to. And then a lot of problems, what we call neuropathy, with tingling, numbness, a feeling of crawling under the skin, sometimes a static electricity sensation on the skin, a feeling of wetness, or the crawling under the skin, we call it formication. And you can have hyperalgesia, where touch can be, pain is exaggerated, or normal touch can be painful, a feeling of vibration. And then we have the joint problems. Unique to Lyme is the traveling joint pain. So my ankle hurt me this morning, then my right elbow, and then my left knee. It can move around. It can be in cartilage. It can be in the lining of bone. It can be in different parts of the musculoskeletal system. And then cardiac symptoms with racing pulse, and when we stand up feeling lightheaded or POTS, and then other less common cardiac problems, shortness of breath, air hunger, that's particularly see that with babesia, dental problems, asthma, swollen glands, and then a lot of people have irritable gut or irritable bowel, nervous stomach that they didn't have before, sometimes gallbladder disease, and that's not necessarily from the treatment. That can be from the Lyme itself. Cyclic vomiting syndrome, where a person vomits, they can't stop. Spastic bladder, you have to urinate more often with a small amount. So this is what makes Lyme multisystem. It affects many things. Hair loss, alcohol intolerance, thyroid problems, on and on. And addictive disorders. And that's my current article that I'm working on, is a certain percent of Lyme patients develop addictive disorders when they didn't have it before. And these symptoms fluctuate, they come and go. You can have good days, bad days. You can get a Herxheimer reaction where you take an antibiotic for a sore throat and it causes a symptom flare. That's often diagnostic. So other studies looked at what are the symptoms. I wasn't the only one who did this. And this was a study done in Johns Hopkins. The number one symptom was fatigue. And on the left there, you can see the severity goes with the dark. So fatigue, joint pain, cognitive, muscle pain, memory, finding words, pretty much the same thing I found all the way down. Although depression, they didn't find as much as I did, but I'm a psychiatrist. And on the other side are people that did not have Lyme. You could see these symptoms are quite mild. And another study done by Johnson and with a big database found the same thing. Fatigue was number one, sleep impairments, joint problems, muscle aches, etc. So very similar to my study. So in all medicine, when you assess something, you don't just do a flawed blood test. You do a complete assessment followed by a history and an exam, a review, and then you think about it, and that's how you make your diagnosis. So if you do that with everything else in medicine, why would you not also do it with Lyme disease? Why should Lyme disease be any different? And the lab testing has deficiencies. So I think this slide probably sums up the state of our lab testing, at least much of the Lyme lab testing that's being used. So you can't go by lab testing alone. And now I developed some screening tests. I'm not going to go through all the details of this because it correlates pretty much with what I said. So I have a short form, which is 24 questions, a longer one, which is 61, and then the full one, which is 200. Now, anybody can download this and do these assessments, and that way it can help with the diagnosis. So the screening questions for an assessment. And these are just a few handful of questions of saying, if you're at risk, do you live in an area where you're at risk? Does your dog have Lyme disease? Do your neighbors or family have it? Did you have a tick bite? Those are part of the screening questions. And then these are the common questions. Similar, now Dr. Horwitz has a screening test and Dr. Burskana does too. So this is mine and it's rather similar to theirs. And it's a checklist that people can do. And then this is the more common list. So this group of symptoms are the symptoms that I just covered, but these are the ones that people have 50% or more of the time. And it can be broken down. I'm not going to go through and belabor this because for time. So it goes through the cognitive symptoms, different categories, the behavior symptoms, sleep, the vegetative symptoms, and neurological symptoms, and the GI symptoms, symptom pattern. And then we have to look at the co-infections. And the co-infections are the other organisms that travel with this, which include Bartonella And how can you differentiate Bartonella? We look for what looks like the stretch marks. We see more of a neurological pattern with Bartonella, soreness in the bottom of the feet, particularly. With Babesia, we can see more in the way of sweating. We may see more air hunger. We see particularly a lot of the emotional symptoms with Babesia and Bartonella. Those three together often correlate more with a lot of the psych presentation. And Ehrlichia, that can hit someone aggressive, strong, with high fever. And then you see the opportunistic virus infection that are in your body that get reactivated. So this goes back to that foxhunt example where there's that interactive infection, mycoplasma. So now the IDSA came out with guidelines, and they basically said, well, these are just guidelines and you don't have to follow it. So, but if they say that, then you should follow that. But then people try to enforce these as standards. They're not standards. And no guidelines are standards and should not be seen. There's a big difference between the two. And they totally missed the boat with psych conditions. So I'll talk about that. So if we look at psychiatry, I did a literature search for Lyme disease causing psych symptoms, and I found 387 peer-reviewed journal articles and 73 of Lyme causing dementia. So that's a total of 467 articles. And they used only 4 articles in their study. And they looked at those 4 articles and they said, well, the evidence is weak that Lyme doesn't cause psychiatric illness. So therefore, don't test someone for psych conditions. If someone has psych conditions, don't think of Lyme disease. That was their conclusion. Now, let me talk a minute about COVID, all right? So if we look at COVID and Lyme, how are they similar? They're both emerging diseases. They both have chronic fatigue. You know, and any emerging disease, a lot of people have trouble with because a lot of people in academia or bureaucracies are very slow to respond to new emerging infectious disease information. So, and this happens with Lyme, chronic fatigue, fibromyalgia, AIDS, Gulf War syndrome, Morgellons, Pandas, mycoplasma, multiple chemical sensitivity, on and on and on. There's this slowness to understand it because of the slowness of how bureaucracies move. How are Lyme and COVID similar? This is a very long list, but they're very, very similar. I don't know if I want to read all this, but they both have very similar patterns. And you often see, now Lyme is an inflammatory, chronic inflammatory condition. And that chronic inflammation then goes with fatigue, brain fog. You also see that with COVID. And however, COVID has some differences because you may see vascular problem like small strokes. You may see lack of oxygen to the brain causing oxygen-related brain injury. So you have some differences. But in both cases, you see a lot of similarities where you get this acute infection and then you get the chronic problems afterwards that a lot of people then spin in circles and don't know how to process that. They then come up with some of these weird names like long haulers or post-treatment Lyme. And there's this belief, well, that we don't understand these symptoms, so we'll just call them subjective and we'll ignore it. And we'll only pay attention to something that a blood test shows, but then you have flawed blood test. And then people jump in and they want to make money with vaccines and testing and say, well, just put up with it until we have a vaccine. And in the meantime, you know, there's money in testing and there's money in vaccine, but there's not money really in treatment and understanding. So that often gets lost. So both have this acute phase and then chronic symptoms, and we want to be able to understand that. So as an action plan, you know, there's competing interest in both cases, both Lyme and COVID. And we have an opportunity here to prevent a lot of death, developmental impairment, suffering, learning disabilities, mental illness, suicide, and economic. And let's do something to help people. I think that's a big thing. Now, I want to talk about a few recent articles. So one is the suicide and Lyme article, and you can find these with Google. And then my article, did infections caused by World War I contribute to causing World War II? World War I caused a huge amount of infectious disease that caused a lot of brain injury and a lot of mental impairments. It may have laid a foundation for mental disorders in a large number of people contributing World War II. And then an article on aggressiveness, violence, homicidality, and Lyme. An article, an overview of Lyme disease, and then my article looking at the proposed Lyme guidelines and a tale of two pandemics comparing COVID and Lyme. And then the article differentiating what's psychosomatic, somatopsychic, or multisystem illness, or medical uncertainty. And then a collaborative approach where we looked at defining chronic Lyme disease. And that was the ILADS working group. And then my diagnostic system, which a lot of this talk was about. And then the article in the textbook about PET imaging, looking at brain inflammation with what we call microglia, and that's out of Switzerland. Then a couple videos. One is the tale of two pandemics, another, and then the Q&A about that. And then using disulfiram to treat Lyme disease, and then discussion with that. Then looking at Lyme and substance abuse. There was a couple of videos I did with that. And then looking at the IDSA guidelines. Pat Smith and I did a critique of that. That's about a 2-hour video. But I saved the best for last, which is The Monster Inside Me. Now that's a Lyme disease documentary, and you can see the trailer. And last night I watched the whole movie. Now, you could say it's a documentary, but it's really, maybe it's a love story, but it really is very inspiring, looking at someone's journey with Lyme and looking at the network, the support person who really stuck in there and helped this person through it. It's a good movie to watch with someone who cares about you, who cares about helping you through this journey. It's quite different than, very different than Under Our Skin. It's a personal journey from the perspective of someone who cares very much about the patient who became infected with Lyme and hung in there. And it's a very emotionally inspiring movie, and we certainly need that because we can feel demoralized by this. Lyme can be a disease of the soul and the spirit, but when you see something that's motivating and encouraging, that helps us to want to overcome these obstacles that we see where it looks like when you have Lyme, everywhere you turn, there's barriers. So that's not out yet as a movie. Looking forward to it being in theaters. COVID has delayed it, but you can at least see the trailer of The Monster Inside Me. So let's open it up to Q&A. I don't know if my video went off, but I'm not sure what happened there.
No, we still see you, Dr. Bransfield.
Okay. Okay.
We see you, and we see your thank you screen here.
Okay. Are there questions? Let me see.
I'll go ahead and moderate the questions. There are a number that are coming in on both Zoom and Facebook, so I have them compiled here. The first question is, can a SPECT scan be ordered through an MD?
Yes. Yes, SPECT scan is, and there's PET scan. SPECT scan are cheaper to do than PET scans. So SPECT scan is more, Dr. Fallon used to do quite a bit of that up in New York. He may still do it. And there was someone there at Columbia that really did some research there. And it shows brain activity. So the usual pattern is scattered throughout the brain, there's areas of decreased activity. And we call that diffuse hypoperfusion. So that shows that there's less circulation. So that measures what part of the brain has more or less circulation. And low circulation to an area of the brain goes with decreased activity. And any doctor can do it. Now, you may get obstacles from insurance companies, you know, saying, well, how do you know you need this? And it's more affordable than a PET scan that you need it's more involved, and you need a radioactive tracer that's, and PET scans are not as common as SPECT scans. So yes, a doctor can order that.
Okay, thank you. Your next question is, Dr. Horowitz is training a lot of new physicians to be Lyme literate. Do you know if anyone is doing the same for psychiatrists?
Well, we're trying to do it, and I have a thing that I've been doing actually for 20 years. It's a internet group for training psychiatrists and others, where we call it microbes and mental illness. And we really want to we've done symposiums. We've done that at the American Psychiatric Association convention and at other meetings. And we were working on trying to and there have been times when a few of us have had symposiums with different psychiatrists, not just myself, but others who work in this area, touching on different facets, like a one-day program. We were trying to organize something, although COVID holds things up. And I've tried doing workshops at times, but we're constantly trying to do that. And would like to do a half day or a whole day. A whole day one would work best, so that we have like child psychiatry, we have psychological testing, we have different treatment avenues. And that's also done at some of the ILADS meetings. A lot of times at ILADS meetings, we have a psychiatric breakout that's part of it, where we do that, and we do training for anyone who wants to learn more about the neuropsychiatric part of Lyme disease.
Okay, that's great. The next question is about disulfiram. I'm hearing from many patients that they are having significant mood improvements on a very low dose of disulfiram, 25 to 50 milligrams daily. Is that your experience, and what do you think the mechanism is that is helping improve mood with disulfiram?
Well, I agree about keeping on the low dose. And Dr. Ligner's article, he looked at going to a higher dose, but I've kind of gone low and slow. And that seems to be the better way to do it. Now, there's also a way that maybe it works as sort of a psych med. And that works by an enzyme that we call dopamine hydroxylase. So you have dopamine, and when I showed the symptoms, one of the symptoms that I spoke about was anhedonia. Now, hedon is a Greek god of pleasure. So when you have anhedonia, there's a diminished pleasure of life. You don't feel the joy of life the way a person normally would. And with anhedonia, so that's that blunting of, and that goes with motivation. When you don't feel joy, you're not motivated. Now, it seems that disulfiram blocks the breakdown of dopamine. So that increases the amount of dopamine in your brain. So not only does it work somehow as an antibiotic, but it also works as a psychotropic in that way by increasing dopamine. If the dopamine isn't broken down as easily because the enzyme that breaks it down is blocked, then that helps give more of a sense of well-being. So I think some people get that benefit in addition to the antibiotic benefit that it gives. And I think that's what the question is related to.
I think it is, because I didn't read the last part. It was asking about the dopamine effect. So yeah, I think you got it. You nailed it there. Next question: to what extent are the neurological manifestations the result of direct infection versus the result of inflammation or neurotoxins crossing the blood-brain barrier? And are there tests that distinguish the two reliably?
Well, that's a good question. I think a lot of people get confused by that. Now, a lot of times people say, well, we don't have proof that you have bacteria growing inside the brain, so therefore it doesn't give brain symptoms. You can't think that way. So think of that it can work a few ways. The main symptoms that we see are, you see infection in the body causing immune provocation in the body. When that occurs, there's various immune transmitters that are called cytokines and chemokines, and these cross over into the brain. So that's why someone may be high functioning in the morning and then have brain fog and not be able to find their way home at night. That it's not like they had spirochetes not in their brain in the morning, but then they have them at night inside the brain. What happens is they get an increase of these inflammatory cytokines, and then there can be an impairment. So it can be a toxic effect. Now, people can argue what are all the mechanisms, and it's a good question. It could be that there's some toxin release, and we haven't looked a lot at toxins in the past few years. There was some work with that more around 15 years ago, but there may be some toxin release, but it's like that one of the earlier slides I showed, some of it's the direct effect and some is the indirect effect. And it's probably mostly inflammation in the body or autoimmunity, but in either case, it's immune provocation from the infection. And the infection, even if there's low number of organisms, can cause quite an immune effect. That then causes the brain problems. Now, separate from that, that's one way, and I think that's the main way. The second way can be what we call vasculitis, where it can be inflammation in blood vessels. And we may particularly see that sometimes with Bartonella. So that affects circulation and circulatory capability to the brain. The third way is where there's actually the spirochetes in the brain tissue. And we've demonstrated that in autopsies, where someone had chronic Lyme and they had IV treatment after IV treatment, and the theory was, well, that's what some people, they use the word standard, but if it was the standard, why didn't it work? They call it the standard treatment, which is a misnomer. But then when they do an autopsy, you can find, and I've sideshown this, of spirochetes inside nerve cells. And I think the people that have that pattern more are the people that show this more rapid downhill dementia course. And that's different than the run-of-the-mill case of Lyme that I was talking about mostly with my slides. So these are the people that have this neurological decline that we used to call pre-senile dementia. And those are the people where the spirochetes are inside the brain itself. And that's the less common. So there's all three of those, but I think mostly it's immune activity, be it inflammatory or autoimmunity. And some of these autoimmune cases can be quite extreme and very episodic, where it attacks the brain itself. So.
Well, here's a question that's kind of related. Do you have a recommendation to calm the inflammation?
Well, you should think of it a couple ways. One is what's causing the inflammation and what provokes the immune system. So the first thing could be infection of some sort or another. So if you have less infection, then you'd have less inflammation. A second could be allergy. Is there some allergy that would make you want to sneeze like you're doing right now? And then is there some toxic substance, or sleep deprivation pushes you more towards an inflammatory state. Chronic unremitting stress pushes you towards a more pro-inflammatory state. Your diet, if you have a more pro-inflammatory diet, that's a part of it. Substance abuse can contribute. So you'd have to go through the list and think, what is there making you pro-inflammatory? You could think of anti-inflammatory treatments, but you also want to think of it a balance. What's making you more inflamed and what can reduce it? And although, anti-inflammatories may reduce it, but you want to look at why are you inflamed?
Okay, that makes sense. And I apologize for the coughing spell I'm having.
Well, he helped demonstrate about the immune system.
Yeah. Well, I'm glad I could help.
Yeah.
Next question. To what extent are the neurological manifestations the result of direct infection versus, oh, no, I'm sorry. I already read that one.
Yeah.
Apologize. If a person was treated for tick-borne infection with antibiotics for 24 months and the physical symptoms improve significantly, but they continue with psychiatric symptoms, anxiety, depression, social anxiety, mood swings, do you restart antibiotics or do you have another treatment? And what about the effects of the gut on psychiatric status?
Okay, well, I think what happens is when you treat, the musculoskeletal things are the easier things to treat. And you see improvement with them first. And then next might be some of the cognitive, and then the psychiatric are the hardest to treat. That takes a more extensive treatment. Although there's a limit to how much antibiotics you can do, you know, it's always a risk benefit. Some people tolerate it better, and what's the price? What's the downside? And so in one of the earlier slides that I called the St. Sebastian diagram, you know, one way of treating it can be treat the symptoms, because the symptoms contribute to disease progression. So how something starts isn't necessarily exactly the same as what makes it continue to progress. So if a person, and that's a lot of the treatment I do, which is if there's chronic stress and sleep deprivation, being in chronic stress makes a person in a more pro-inflammatory and immunocompromised state, and sleep deprivation does too. So I will treat whatever symptoms contribute to that chronic stress and chronic sleep deprivation. So if a person's stressed with panic attacks, then treating the panic attacks might help. And a lot of times when I see someone, it may be someone like the person that had 2 years of antibiotics, but maybe no symptomatic treatment. Then I'd say, well, let's treat the symptoms, because the other approach didn't quite do it. On the other hand, I may see someone who's only had the symptoms treated, but the infection was never treated. That's the person who might do better with an antibiotic treatment. Sometimes you need a combination of both. Now, the problem can be is if you load someone up too much with antibiotics, are you going to have some negative effect on the gut? And Lyda Matman did research where she showed that spirochetes, Lyme, grows inside yeast cells. So if you think of that, if you give too much antibiotics, you can promote yeast overgrowth and give a place where the spirochetes can thrive. So you might have to also address the yeast, but you're doing that sometimes with your antibiotic treatment. So we think of the gut as part of what we call the microbiome. And the microbiome is we're a microorganism, and 90% of the cells in our body are microbial, not human. And there's this interaction. We depend on these, a good culture. But the microbiome, the human microbiome, isn't just in the gut. It's in other parts of the body too. We can't just look at the gut. But you don't want to throw that off. Now, sometimes that can be the advantage of the disulfiram, which is that can act as an antibiotic, but it can be more selective. And you usually don't see that yeast overgrowth problem or as negative effect with the gut. I did have one patient that had a yeast overgrowth related to it, but that's about it. But it's that can be a way to try to get around it. Now, some people feel, well, maybe IV or intramuscular may be less prone to be hard on the gut, but even there it can happen. So it's always a balancing act. Some people are just very susceptible to those negative GI effects and other people aren't. And you don't want to disrupt the normal flora of the gut. And you want to think of what keeps it in balance and use probiotics. But it's a balancing act, and it has to be individualized. You can't say, well, so many weeks is always what you give. It's always, individualized with each patient. All treatment is personal and individualized.
Well, Dr. Bransfield, we're coming up on 8:30, and we have a number of questions left. Do you have a few minutes?
Yeah, I'm
to
okay.
spare?
That's fine. Okay.
Okay, I appreciate that. Then I'll keep going with these questions. This next question was someone that emailed me ahead of time, and it's about parasites. This person had found that detoxing of parasites was extremely important to her daughter's health, and just wanted to know your opinion on parasites in treatment.
Well, if we go back to that complex interactive infection model, like when I showed the foxhunt picture, parasites can be a part of that. Now, if you look at what Dr. Berdorfer was looking at, he was looking at nematodes, and nematodes come up and they're parasites. And a Lyme can be inside nematode, just like when I was talking about yeast cells. So are we missing something by only looking at the Borrelia? The microbiome, but particularly the pathological microbiome, the organisms that interact to cause disease is a lot more complicated than we recognize. It's not just like a strep throat where you do a culture and then you have one organism and you did one treatment and that's all there is to it. And the more we look at that, there's more pieces to it. This is a complex interactive infection. And you have to look at parasites as well. Now, therefore, some of the anti-parasite treatments some people are using. Now, if you look at, let's say, the disulfiram, that was originally developed as a parasite treatment. And we're seeing this overlap when we treat COVID, that we're using anti-parasite drugs, like things that we use from malaria, or let's say the ivermectin. And it's like, well, why would that work with a virus? Maybe these things have a crossover, but it's not just the bacteria, it's not just the opportunistic virus, or to consider yeast, but it's also parasites, and it may depend on any given person, that may be a bigger part of the piece for them. So it's good to tease that out. And I think as time goes on, we'll recognize that that's a bigger piece than we used to think, just like, and may go back to the nematode question. How much is that a piece of it? But it's not just nematodes, it's other parasites. Or Babesia is a parasite. It's a parasite we call pyroplasm, like malaria. And so that's one parasite that can be part of this complex interactive infection.
That's right. Okay, so the next question is, have you ever known Lyme disease to be misdiagnosed as schizophrenia?
Yes. Well, maybe let's not make confusion. If a person appears schizophrenic, schizophrenia is a symptom complex. So just like depression is a symptom complex, Lyme can cause depression, or it can give a schizophrenia appearance, or it can cause other things. But if it causes that symptom, you do see that symptom, but other things can cause that symptom too. Like one parasite that we think of as being associated with schizophrenia can be toxoplasmosis, and sometimes different chlamydia infections. So schizophrenia is a consequence of something causing impairment in the brain that has a syndrome of symptoms. That's what schizophrenia is, but the cause of that could be multiple things, one of which might be Lyme, and other things can do it too. Now, I have a number of patients that present with schizophrenic symptoms, and then you treat the Lyme and you see the schizophrenic symptoms improve. And but many of my schizophrenic patients, I think however they got there, and maybe it was some infection maybe 10 years before, but that doesn't mean that treating it now would reverse that. Because once the disease has been progressed to a certain point, it's very difficult to turn back time and reverse that. So there can be what we call maybe hit and run infection, where the damage is done and it's done, and treating it after the damage is done isn't going to make a difference. So how much of that damage is from old, be it infection or other disease provocation and disease progression, and how much of it is done by current infections activity that exacerbates the symptoms. So if someone's had schizophrenic symptoms for 20 years and then you suddenly discover Lyme and treat it, I don't think you're going to turn it around. But if someone has a very recent onset of psychotic symptoms, and you see that associated with some infection, be it Lyme or otherwise, and you treat it, then you have a much better chance of improving the treatment. And there we usually do the combination approach, where we give the psych meds that we know help the schizophrenia or the psychosis, and we look at antibiotic treatments that might be effective, and that combination can be better than either one alone.
Okay, very good. Next question is, in your opinion, what is the best detox for neuro-Lyme?
Well, when you say detox, what are we detoxing, all right? And I think a big thing with toxicity can be what we call quinolinic acid. And quinolinic acid is something that you see increased with Lyme. We can also see it with malaria. We can see it with HIV. We can see it with any disease that really is hard, any infection that affects the brain. And quinolinic acid occurs when tryptophan doesn't have the normal breakdown. We think of tryptophan as one of our essential amino acids that would then turn into melatonin and serotonin, which are good things that we want. But in a highly pro-inflammatory state, there's an enzyme that's abbreviated IDO that gets more activated, and that shifts. So rather than getting the serotonin and melatonin, it instead shifts a different pathway that's more quinolinic acid, which is more neurotoxic. So we have a neurotoxin produced instead of something that's good. So anything that shifts that balance back can detox that. But when we detox, what are we detoxing from? Is it quinolinic acid, or is it some other toxic substance that adds to it? Does someone have heavy metal poisoning? Is someone are they chemically sensitive? Is there some other mold or some other toxin they're exposed to? When you detox, you want to look at what are we detoxing from and try to remove what that toxic substance is. A lot of disease can be infections, toxic, or deficiencies. So a deficiency is where you don't have enough of something. A toxin is where you have too much of it. And you want to identify what the toxin is and then try to eliminate that. Now, I know that Dr. Horwitz focuses a lot on some of his toxicity strategies, and other doctors do too. And with the thinking of be it heavy metals or other things, that when you can identify that and remove that and reduce that, then you may have a better outcome with that chronic infectious process that is more perpetuated by the presence of that toxicity.
Okay, we have a number of questions left. I think I'm going to wrap it up here, though.
All right.
So another question, do traditional psychiatric medications work to treat neuropsychiatric Lyme?
Yes, they do, but I think you have to use them differently. You need to be careful that some Lyme patients are very drug sensitive for a couple reasons, one of which may be low body temperature, but other reasons too. So a lot of Lyme patients, they can benefit, and I give a lot of the standard psych meds to Lyme patients, but I often have to treat with very low doses, at least initially, and sometimes ongoing with some patients. So people make the mistake sometimes of starting with too high of a dose, but you want the med that's appropriate for the symptom. When I do an assessment, and like my research showing 82 symptoms for the average person. Well, if you have 82 symptoms, do you give 82 drugs? No. You look at how those symptoms interact, and what's the more pivotal symptom, which is often chronic, whatever causes chronic stress or sleep deprivation. And that's the symptom that, and if it's a psych symptom, or if it's a non-psych symptom, then you'd want to give the med that might help that symptom. But start at a low dose and look at the reaction. And you always have to be careful that any psych med can give an opposite reaction in anybody. A stimulant could put some people to sleep. A sleep aid could wake up somebody. And so always look for that unusual reaction, but be careful about overdosing. I think that's the main problem, is that people give too high a dose too quickly, and then they think they can't use the psych meds, or they only look at the psych meds and they don't look at the other pieces, like the infectious piece. But I think the psych meds, the cognitive meds, they all have a place, but you have to balance it and use it in the right dose with the right timing.
Very good. Well, Dr. Bransfield, I thank you so much. I think we could talk to you all night, but I think we're going to have to cut it off there. Appreciate your time. Appreciate all your expertise. We will have this presentation available if anybody wants to watch it again, or if you want to share it to somebody. It will be on our Facebook page, PA Lyme Resource Network. It will be there indefinitely. It will be there. Every virtual Lyme series that we've done is still out there. And in the next day or two, it will be on our website, palyme.org, which links to our YouTube channel. So it'll be there as well. And look for our next PA Lyme Virtual Impact Series webinar.
Okay, month. Thanks for inviting me, and thanks for all the questions and everybody's interest. And I hope we move forward with this. And I hope that cartoon that I showed from 25 years ago is different a year or two from now. My hope is the attention with COVID might get people more aware that infections cause all these things, including psych symptoms, and maybe that can move things along quicker. And I'd like to mobilize public awareness, and people, general awareness. It takes a long time for people to understand something so complicated. Well, and things like this help educate and help move things forward. And thanks for doing it.
Well, it is sad that it's been 25 years since that cartoon and things aren't that much different, but we are here to educate and to help change that. And let's hope you're right about COVID helping us in some way with this. Okay. Good night, everybody.
Thanks. Good night.
Good night.